There is a lot of controversy going on right now about the relative roles of open and minimally invasive partial nephrectomy, and I wasn't sure what my predecessors were going to say here, so I've put some various things together, and some of it I'll speak to quite quickly, but I want to give my acknowledgments to one of my partners, Tony Finelli, who has done some of the work I'm going to present, and Simon Tanguay, who's now the Secretary General of the SIU and is at McGill, who also helped me with some of this, and one of our current fellows, Ashraf Al-Matar from the Eastern Province in Saudi Arabia, who's an excellent guy after a few months working with us. So I grew up surgically in Toronto under the tutelage of Chuck Robson, who really codified the radical prostatectomy, radical nephrectomy procedure. And it's hard to imagine now, as we're, his final report was in '69, but this started right after the war. And he was a very loyal BAUS member, came to many of your annual meetings. He did some postgraduate training here after the war. I used to hear about some of your ancestors as I was a resident, and in fact came with them to this building as a young consultant, about 10 years younger than your average resident's age at that point, and heard why it took, you had to be 40 before you could be a consultant. It was an interesting experience. I'm glad that you've moved on from that. But really, we grew up with thoracoabdominal nephrectomies for T1 tumors because most of them weren't T1 tumors at that point, and we've watched this evolution, which in North America was really led by Andy Novick from Montreal, but spent his life, which tragically ended prematurely, at the Cleveland Clinic, and one of his recruits who's carried it forward now in California, Indy Gill. And in Europe, I guess Hein van Poppel was one of the early players that really took something exceedingly controversial, and they were widely castigated for this concept of taking out part of the kidney, as some of you will remember, but it was being done in people with solitary kidneys and impaired renal function initially, but then very tentatively over the ensuing years in the 90s, this was suggested that it could actually be done because of apparently equivalent oncologic outcomes, which we now know are virtually 100% disease-specific survival into the patient with a normal contralateral kidney. So I've learned whenever I travel to look at local practices, and I looked at your maybe not so nice documentation, and on partial nephrectomy, one of the positions, which albeit is almost 10 years old, alludes to a couple of things which are quite topical. There's no published RCT evaluating the effectiveness of partial nephrectomy, and that was published in 2002. And in fact, the evidence, the RCT, which I'm going to finish my discussion about, was published this year. And it had been work in progress from the 90s. And the other thing is that the role of the retrospective studies evaluating the value of partial nephrectomy in terms of complications and tumor control, that this evidence really was all we had, and in fact that was all we have, and it's what we actually go forward with despite the RCT. And then I thought this was quite an insightful statement, given that it was published 5 years ago, and you people are probably quite familiar with this guidance, but the indications for lap partial include a solid renal mass in a patient with a solitary kidney or compromised contralateral kidney, bilateral renal masses, small localized tumors in patients with a normal contralateral kidney. I thought that was quite an interesting statement to make 5 years ago, and it doesn't seem to me to be consistent with some of the nice evidence-based guidances. I wouldn't actually have thought you could say that then or even now. So we've already talked about this driver of CKD to partial nephrectomy, and for us in North America, the citation is the Go paper in the New England Journal, which was written 7 years ago, and this was based on large population in which the GFR predicted for death, we've heard in another study, and also hospitalization and cardiovascular complications. So that was really the first thing that caught our attention, and then that was extrapolated by Bill Wong, now at NYU, I believe, but when he was a fellow at Memorial, looking at their patients that had had partial versus radical nephrectomy at Memorial Sloan Kettering, with Paul Russo as the individual who really led this study. And they retrospectively just looked at the two outcomes and found that the probability of being free of renal dysfunction was much higher in the partial nephrectomy population. And that was really the first time that we took the GO data in the general population and started to look at it in renal cell carcinoma, and that was updated, as we already saw this slide earlier, in the patients who had had partial nephrectomies for actually benign disease. So there have been a number of other studies looking at this issue of overall survival, cardiac complications, and so forth. And in the interest of time, I'll just quickly show these slides, which basically all speak to the same thing. Lou has alluded to ways we can predict and explain some of this, and one thing that's very interesting to me is nephrometry, as we call it, which is looking at renal volumes before and after partial nephrectomies by taking the digitized images of CT scans and trying to exclude renal pelvis and tumor volume, and then looking at the kidney volume after surgery. And one of the problems with partial nephrectomy is I actually think it's the wrong word now, that we don't take out much kidney. And for those of you who do partial nephrectomies and volume, I suspect you are increasingly enucleating tumors with very little normal kidney with it. And we call it the Saturn effect. You get the specimen, you see the halo of the renal cortex, and then you start to hug the tumor as you go down towards the renal pelvis, particularly in larger tumors, so much so that we actually have a hard time evaluating normal kidney, and we don't do heminephrectomies anymore. We take out the tumor with a little bit of kidney, and the actual bleeding is coming from the normal kidney tissue that you're skimming by and the vessels in that normal kidney tissue. So it may well be that the loss of kidney tissue that we measure in these nephrometry studies, we can do this in RFA where it actually correlates better, is due to these sutures we place and various other interventions to stop normal vessels from bleeding. And when I look at Indy Gill's data you alluded to with the little clamps and so on, I think what he's really doing is clamping the normal vessels that are often being displaced by the small renal mass. And when you look at the images, for example, we've taken kidneys out and down to the CT scanner and perfused them before taking them to surgical pathology. We really have a hard time identifying vessels that are giving that increased uptake on the diagnostic CT scan. They're certainly not major vessels. Oh, the other thing I wanted to say here was this urinary marker story, if I can just get myself back to that slide. So markers of AKI done prospectively is an evolving field, and as you may know, that intensivists, nephrologists working with patients that have had cabbages and so forth, they're looking for predictors of dialysis and the requirements for dialysis, and there are point of care instruments now that you can measure things like NGAL in the urine of patients and in the blood of, well, I guess the blood of the patients, and predict within hours, certainly within 24 hours, of the degree of acute kidney injury. And it may be that we can do that, and speaking to some of the work that you're talking about. So I think there is something happening here that we're going to be able to predict better. So there's one area of open partial nephrectomy. We often think of an indication are the very large tumors, and we certainly are seeing an expansion of indication for partial nephrectomy into the T1B and even the T2 tumors. And this concerns me a great deal. We saw that pathology slide before the coffee where there are fat implants or vessel invasion of tumor, and increasingly we see higher grade tumors in these large kidney tumors, and it worries me as we push these indications with what does appear to be a valid indication. And Brad Leibovich at the Mayo Clinic was one of the early pioneers in showing us that it was appeared to be safe and equivalent to doing radical nephrectomy, and I won't go into the details of that. The New York group at Memorial and the Mayo Clinic pooled a large number of patients, and this was, mind you, retrospective, so these are tumors that were probably more amenable to partial nephrectomy rather than radical nephrectomy going back over many years, and have an apparent similar oncologic outcome. But I'm not sure that as we push the envelope, we're not going to get local recurrences and other unexpected consequences from doing this. And there's several papers that I won't dwell on this. But what I want to do is show you some of the data with partial nephrectomies. In Canada, like you in Britain, we have some opportunities. Even though we privately deliver health care, we do it with public money, and that means that there's an accountability and reporting that goes on a population basis and allows us to do things that are quite useful. So by merging databases, we can see things in a quite granular way for every nephrectomy being done. So this is first from my province in Ontario, which is a third of Canada roughly. We do about 1,000 renal surgeries a year, and you can see over time what's happening in a lot of countries, that our open radical rate is going down, our partial nephrectomy rate is going up, and our laparoscopic part of the radical nephrectomy has gone up. And I think all countries are seeing this sort of thing. When we look at it a little more detail, and we look at the partial nephrectomies, which are these crosshatches here, this line here, you can see the increase, but it's still in our jurisdiction is about 20%, just over 20% of the patients, and it's working up. It's interesting also looking at things like positive margins. We've done this with radical prostatectomy and found on our first cut of the data that we had 60% of our radical prostatectomies were positive margins. I think there were a lot of issues in that on pathology and so on, but we've brought that down by KT efforts. And this in kidney, we have 12% positive margins on the tumors that were removed by partial nephrectomy, which is in stark contrast to the percentages in the centers of excellence doing large volumes, which typically are 2 or 3% at most. So these things don't necessarily generalize well. And that's because of this kind of data, that this is the partial nephrectomy numbers done by institution, and you can see, for example, our institution by far the largest, but look at all the institutions doing less than 10 cases a year. In fact, the vast majority, and I suspect it's the same here in the UK, and it's a surgeon thing too, that there's relatively few surgeons doing the vast majority. And that, you would think the volume outcome relationships should be shown in complication rates and so forth, and then I'll show you in a minute it is the case. In the US, there's an increased rate of partial nephrectomy going on, and we would argue currently, I think all of you in this room, that we should see a very high rate. We don't know what really it should be, what our target is, but it should be a lot higher than 40%. In Ontario, we're substantially under 40%, but we're getting closer. We actually don't know where that number should be. It won't be 100%. When we take this to Canadian numbers, this is 25,000 renal surgeries by year, and without going through all the details, we can see that nationally the partial nephrectomy rates going up, and this is in 2007. There's a little lag in some of the data. I don't know what, maybe it'll come out in discussion, your rate is here in the UK. But when you look at it by some metrics like age, you might think, based on what we heard from nephrology, there should be a higher rate of partial nephrectomy in older people who have a higher CKD rate, and it's exactly the opposite. Actually, the older patients are less frequently offered partial nephrectomy, and we might want to talk a little bit about that. Income has an impact, and our society is a little less skewed than British and American incomes, but it's moving rapidly that way, and people with higher incomes have a higher rate of partial nephrectomy. Comorbidities, you'd think that maybe there would be a difference, and there isn't. These are large numbers. This is national data. And there's a fee schedule difference in our country going from province to province, and there is a slight tendency, I won't go into the details here, but the higher reimbursement jurisdictions for nephrectomy compared to partial nephrectomy seems to be in part reflected in a lower rate or a higher rate of partial nephrectomy. So that's not a particularly proud statistic if indeed it's true, and it's just a trend, but you can see, say, 13% to almost 19% here. The physicians that do a lot of kidney surgery tend to do more partial nephrectomies. Remember, this is going back over a period of a few years, but volume seems to lead to partial nephrectomy, similarly in institutions. This is interesting to me, that hypertension, you might think, would be an indication to consider partial nephrectomy, but it isn't, or hasn't been. Maybe going forward it will be. Complications on a population basis are quite high with renal surgery, and you can see radical nephrectomy and partial, though, are quite similar, which isn't totally intuitive. Mortality rates are different, and I think that probably is just historic, that the worst patients were having radical nephrectomy. I don't think that's really the reflection on partial. Now, in the interest of time, I won't go through all these details, but there aren't some of the differences that you would expect in different issues, as I've pointed out. Complication rates, fortunately, are going down over time. And in-hospital mortality rates, this is an interesting statistic. There's a strong correlation with age. This is in-hospital, and you can see from the younger to the older age group, there's quite a difference. So in summary, partial nephrectomy is going up. It varies across the country with different parameters, and we don't see prediction of the use with comorbidities, and I won't go into any more of that. So let me just speak to this issue of the present vision of partial and robotic laparoscopic, which I think we're moving rapidly to robot-assisted laparoscopic surgery versus open surgery. And this is common perception out there, I would say, by our patients. I tell you that we do see all our patients together in a tumor board where there is interventional radiology with us, and we assign cases to some degree based on the tumor size and location, but we actually can't accommodate everybody in this side, so we default sometimes to open even where it could be managed on this side. For the hospitals, when you're going to talk about doing this procedure, there's a strong appeal to asking for this instead of this, and since our healthcare system is siloed and the hospital costs are not in continuity with the whole experience of the patient, it costs us more money to do minimally invasive surgery. So the open surgery actually is quite appealing to our hospital, and we don't cut off much time. So why and when would I choose an open? And I'll quickly go through this. So the more complex procedures, big tumors, the location in the kidney, whether or not the collecting system is at risk, multifocality, cystic lesions, and if patients have extremely limited renal function, we generally default to an open procedure, thinking we can control the situation a little better. I suspect on Long Island that wouldn't be a consideration to the same degree maybe that it is with us. This question we've already spoken about, every minute counting in terms of the time of ischemia, and I really don't know what to think about this. We do cool the kidney mostly. We're about to start a trial where we're going to randomize patients between cooling and not cooling, clamping the whole hilum. We're doing that in Ottawa, Toronto, and Rochester, Minnesota, and we're going to study about 500 patients, so we hopefully will have an answer for this, and it's not a very simple study to do. The whole question of warm ischemia, I think you could couch this argument either way. I personally choose to cool the kidneys. These are just 3 quick examples of the kinds of things that I would lean towards doing open. Multiple tumors, these cystic lesions I would do open, and some of these very central lesions, which we are increasingly doing and coming right down to the renal hilum. And in fact, there's really no kidney tumor now that we couldn't do a partial nephrectomy on within reason, but hardly ever, and going into the renal hilum and so on, the only thing was we'd do them open. Just quickly, technically, I'll just touch on a couple of points. We would insert a ureteral catheter as the patient's being anesthetized with a flexible scope if we think we're going into the collecting system, because I can then put in a colored dye and more easily find the collecting system to close it or to detect a leak. I also sometimes can't tell the collecting system versus a vein that's stretched over some of these tumors, and I have had the misfortune of dividing what I thought was a vein and finding it was an infundibulum, and I found that by doing this it's quite helpful. Complete mobilization, we do this inside the perinephric fascia, under the perinephric fat, as opposed to mobilizing outside, which is what some centers do. And I find that useful for 2 reasons, one of which is that I expect to reoperate on a number of these people for recurrent tumors, and by having that fat closed, I think it's easier to re-expose the kidney and not just have an incision go right into the renal parenchyma. I don't find ultrasound terribly helpful. I find once I start doing something to the kidney, I can map it out, but as soon as I start operating on the kidney, I lose that definition. We do it, but I don't find it as helpful as one would believe. We do mannitol. We don't worry about clamping the hilum, particularly when we're cooling with ice slush. And we no longer do frozen sections of margins, and if a margin's positive, we don't go back. I think that's pretty well standard practice now. So as I said, we fill up the wound with slush after clamping the renal hilum. For not very good evidence, we wait 10 minutes, as long as the surgeon can wait. Maybe we can't quite make 10, but we try. And we give mannitol before we do that, and we give mannitol, in theory at least, before we unclamp. The whole issue of zero ischemia is something which I think all of us are working towards, and whether you're doing it open or laparoscopically or robotically, this buzzword of zero ischemia I think really just speaks to the way you enucleate these kidneys. Some of the technique I think I'll pass on, but we're very big believers in glues, particularly FlowSeal, which is quite expensive, and now that we count this, it drives up the cost dramatically, particularly if you use a second syringe. We just basically do what I think all of you do, and you can make quite large defects in these kidneys. I don't worry about leaving metal clips on these vessels, by the way. I actually find it useful to follow patients post-operatively to see if the suspected lesion is expanding. I'm just very careful that these aren't going to be in association with the collecting system. So I think really the surgical approach has to be adapted. Open should be in the armamentarium. I don't think a big discussion on open versus lap is that critical, but I often hear people say that who aren't doing minimally invasive surgery. We send the patient to whichever team is going to be able to do the best job. So I don't think I'm less credible by saying this, but it's clearly a safe and reliable approach. Thank you.